Welcome to Expanding Access, a podcast by Behavioral Health Tech, where we explore the cutting edge of mental health, substance use, and autism and IDD care. Each episode features insightful conversations with industry leaders who are driving real change through technology and innovation. Whether you're a provider, payer, or just passionate about expanding access to behavioral health care, you won't want to miss these stories. Let's dive in. Hello, everyone. I'm Solome Tibabu, your host for the Expanding Access podcast, where we're talking about all things expanding access to high-quality behavioral health care, particularly through technology, innovation. So, of course, today I am so thrilled to have our data and interoperability guru friend, Helen, here with us. Thank you so much for joining today. To get started, can you share just a little bit about your background and how you got into this space?
Sure, absolutely, Solome. Thanks for having me. I'm so excited to do this podcast with you. So I'm a healthcare data privacy and interoperability attorney. That's probably the best way to describe what I do. I focus pretty much all of my time in the healthcare space. But I like to share with people that before I went to law school, I actually had quite a bit of time I spent in the mental health space. I had aspirations to go on for a PhD in clinical psychology first before somebody changed my mind and I went to law school. So I like to hope that I have some background and understanding of the individual, having worked as a clinical social worker and a discharge planner in halfway houses, transition houses, working with many different populations, sort of gave me a perspective. I worked in a nursing home for a while. And seeing, quite frankly, how this population just really needs the continuity of care, because as you know, behavioral health, substance use disorder is one thing. And those are very important things that your company and it needs to focus on for treatment. But then many of these populations also have general medical clinical issues, whether that's diabetes, coronary, heart disease, cancer, whatever. And so I think that segues really nice into our discussion today, because I've focused a lot of my legal practice on understanding the rules for consent, how to balance data privacy, consent, and the person's choice to share their information and with whom, with the evolving technology opportunities for sharing that information, first through EMRs, through health information exchanges, and now through AI. And so there are a lot of benefits, as you know, in the work that you do to leverage technology for being able to address the clinical needs, the mental health needs, behavioral health needs, and other needs of the individual through that sharing of information. But, I help organizations balance the legality of how to do that.
That is just incredible. You do not pick the easy jobs. What
For sure not.
Such a diverse experience and has led you to this really important work. And something that you were already alluding to is that behavioral health data is often described as, of course, both essential for innovation, but uniquely sensitive. From your perspective, What makes mental health and substance use data really different? And why would you say privacy and consent matter so much more in this space?
Well, starting with my legal hat on, it's different because in many instances, it's treated legally different. It's protected under higher standards. Many of your audience who are listening are probably very familiar. And actually, many people are familiar with HIPAA as our baseline privacy law that protects many medical records. But people are maybe less familiar sometimes with 42 CFR Part 2, which is another federal law. That law was enacted early 1970s, and it is intended to protect specifically substance use disorder, protect information and records, because that has been used to discriminate against individuals, whether it's in the employment workplace, in the enforcement work situation, or in other sort of circumstances. And so Congress felt that there was a need to protect and to apply higher standards of not releasing that information without proper consent. And similarly, we see that in many, many state laws that have regulated in these space, both in the behavioral health sector and the substance use disorder sector. You'll see laws that go beyond the floor of what HIPAA requires. So, for example, maybe the audience has heard many times, we can share medical information for treatment purposes. Well, that's actually true under HIPAA. You wouldn't need an affirmative, say, a person to sign a consent form if you're sharing information with one doctor to another doctor. But interestingly, with regard to 42 CFR Part 2 and many similar kinds of behavioral health and SUD laws at the state level, you actually have to put that power back at the consumer. Say, are you sure? Which doctors do you actually want me to share this information with? And are you okay with that? And so to answer your question, what makes it different is that we have to be much more careful with sharing that kind of information because there definitely are more rigorous standards and less latitude in sharing that information without proper consent of the individual, giving that power back to the individual, making sure you ask, who can we share this, even if it's in a clinical context?
Yeah, that's so great because I feel like often we hear from providers, innovators in our space that interoperability is framed as the solution to fragmented care in behavioral health, but it does seem risky for behavioral health providers. So can you tell our audience a little bit about how frameworks like TEFCA can change this conversation and what safeguards are really critical to getting that provider and patient buy-in?
Yeah. And I think where I said originally is that balancing, right? Where I spend a lot of my time. And some of that has been moved forward with the opportunities that technology has to do things with data that it hasn't been able to do in the past. For example, when it was on paper, it was very difficult to even move information. Now that information has become more liquid and digitized, it has the ability to move. But in the past, it's actually been packaged together. It was sort of like an all or nothing. And I've been in this space for a long time. And I can just see now, 15 years into this space, now we're getting into technology interoperability models, technology solutions, FHIR-based bundles and packages where you can do things with data. You can actually begin to start transporting consent preferences with the data. You can start to bifurcate and sort of package data based on the type of data it is. So we're starting to get to a point where there's really opportunity. So that circles back to your trust factor and ability to balance. So it's important. So we're at the precipice of technology being able to strike that right balance between sharing it because yes, that patient has behavioral health and SUD issues, and that may affect a surgical procedure that person may need because they have certain medications they're on or whatever. And so it gives us an opportunity to maybe share just pieces of that information for a specific episode of care or whatever, and all the combinations in between. But to your question on TEFCA, there's still opportunity for abuse, right? And there's purposeful abuse. I want to say purposeful because nobody really purposefully abuses these things, but I think it sometimes comes from ignorance and not fully understanding things. And so standards or just sharing things by not fully understanding, the buzzword now kind of in the legal privacy space is privacy by design, right? You have to really understand the legal framework so you can allow for the things to happen in the proper manner. That's the way we balance. And that's what organizations and structures and governance structures like TEF are really paying a lot of attention to. They have a super amount of really smart people working there. They've leveraged the work that was done like in 2010-9 with DERSA, taken all the knowledge and now have revamped it for the current state. And so it's really a trust framework and, not to throw trust around loosely, like you really have to understand the underlying issues because if we don't create a privacy framework by design, we risk doing things loosely and then we lose the trust and then we lose the opportunity because all it's going to take is this information to go in a sloppy manner, whether intentional or not. And a lot of times it's not intentional, but it's intentional in the sense that organizations have respective duties of care to understand what those requirements are to strike the right legal and operational balance so they can get all the benefits of sharing the data without breaking the system and leading to something that happens a year or 2 years down the line where the information's flying everywhere, it's getting sold, it's getting packaged, who knows what. And then it's going to lose the trust of the patient and we're going to lose those opportunities. So the message, I think the takeaway point to your last question is, my message would be to make sure that organizations are approaching this with the duty of care that they need and with an understanding. The Sequoia Project, if you've heard, that's sort of the governing organizations that's putting those rules. They have many incredible resources they're putting out right now. We focused on 42 CFR Part 2 specifically with the operational guidance that we've put out recently and providing like detailed drill down on what are the consent elements? What are the things you need to do to operationalize this at your organization? So I encourage your viewers to talk to others and understand what you're doing first. Don't get scared from approaching the opportunity, but go into it with the correct resources and knowledge to get it done and to create that privacy by design and that framework that's going to allow you to do it in a really trusted way.
So well said. So much trust needed for this space. And for those in the audience, that's Helen had mentioned the Sequoia Project. That's sequoiaproject.org. And for our newbies in the space, TEF, Trusted Exchange Framework and Common Agreement. Man, there are a lot of acronyms. High tech.
I know.
In fact, I'd love to ask you a question about 42 CFR. But before we do, for our audience who might be unfamiliar, what is 42 CFR?
Yeah, it is a federal law. You might find, depending on where your audience is sitting, you may find similar kinds of rules that are at your state level. But its intent is to protect substance use disorder treatment information. The policy behind it, of course, is to encourage people to go without the fear of retribution. Substance use disorder information in particular has historically been used for things like enforcement actions. It can be used against individuals in child custody. It can be used for employment context. There's just a lot of misuses of the data. And so Congress felt it was important enough that we needed a very strong federal law to encourage people to get this kind of treatment without the fear of retaliation. And so that's what we saw. 42 CFR Part 2 is actually the regulatory section that has those consent provisions and those restrictions and the confidentiality that apply to that. That law did just go through a huge overhaul. And as we just talked about, Congress did update it for the first time since the 70s, recognizing that things are changing. Technology is providing new opportunities. And the intent was to strike the correct balance between allowing some of that information to be shared in various contexts. But again, going back to my point, you got to understand the baseline rules. And I know it's a heavy lift, and there's a lot of great organizations, including ourselves, who are putting out information through our blog and other, and Sequoia, and everyone understand what these things do, the rules and what the consent standards are before you dive in. I think that's the best way to do it. So that's 42 CFR Part 2. You may see similar things. And at the state levels, I'm sure many of your listeners and customers and clients and whatnot, a lot of times there's duly certified facilities and units, so meaning that they have at the state level a duly certified BHSUD unit, so people who are having behavioral health and substance use disorder. So you may find yourself with intersecting and overlapping laws. That does get complicated. There are member organizations out there helping people sort of go through that. Is one of the things that we work very closely with a number of member organizations, parsing through those consent standards or whatever. But that is what's 42 CFR Part 2. It's a super important federal law, and it's kind of getting a lot of attention right now because of the changes that have happened that actually just went into effect February 16th of this year. So it's an important thing to sort of get up to speed on.
I mean, heavy lift and complex are great words to describe some of these things. And in fact, 42 CFR Part 2 is frequently misunderstood as a barrier to care coordination.
Yeah.
Based on your experience, can you talk a little bit about how Part 2 compliant consent and data sharing practices can actually expand access and improve outcomes?
Yeah, that was one of the main goals with this last iteration, because in its prior form, in the 70s form, and even with some of the changes that have happened over the last few years, an attempt where SAMHSA tried to adjust those, the baseline was that it was constructed for paper. So no piece of data or information was ever leaving, an SUD or a behavioral health organization without a paper consent every single time, where you're like, it's going to point B and I'm disclosing it to point B, and you actually have to write point B's name on the form. And so that got carried over. And now that we're moving into a fluid digital environment and there is opportunity for care coordination, other individuals who are involved in a person's whole self and whole care, whether it's community care, whatever, the way the structures just did not allow for naming of every single potential recipient of that data. And so this last overhaul carefully, I think, tried to balance and allow that kind of a barrier, which was one of the major barriers, is the naming of the recipient with specificity, and allowed some latitude with that. So you can now describe specific groups like clinical providers who are directly involved in treating me, unless I otherwise specify and say I don't want this provider. So there's an opportunity now to more generally describe that and allow for better sharing opportunities. The trade-off, or I'm not sure if it's a trade-off, but the balancing that SAMHSA struck with that is like, okay, and Congress struck with that is, okay, we're going to allow for that. But now we're going to overhaul the entire enforcement mechanism for 42 CFR Part 2. So historically, there's been zero enforcement for Part 2, nearly. I don't know of any case. But now, as of February 16, 2026, for organizations who are using these new mechanisms for allowing for broader sharing, if they violate any portion of Part 2, they will be subjected potentially to civil monetary penalties, much like we've seen in the HIPAA space. That is brand new. It also has extended opportunities for enforcement at the state levels, as well as potential criminal enforcement for egregious situations. It really needs intent and misuse. But I think the point is that, yes, so for care coordination, there's more opportunities, but again, understand how to do it, making sure the systems are in place there, the safeguards are in place, the structure's in place, because the risks are a little higher now in the sense that if you don't do it properly, you can actually be faced with civil monetary penalties for noncompliance. So,
yeah, for the providers, innovators, all stakeholders in our audience, obviously, you don't want to mess around with that. And speaking of stakeholders, I know, Helen, you and your team, you work with a wide range of them: providers, health systems, HIEs, health IT vendors, payers, the list goes on. What have you found are the biggest misalignments you see between these groups when it comes to sharing sensitive behavioral health information? And where do you see governance and consent models can help to bridge some of those gaps, perhaps?
That's an interesting question. So some of the disconnect, I'll start with that. Each of those groups you just named, they're standing in their own shoes. And let's just take Part 2 again as the baseline example. So the rules apply similarly to each of those kinds of organizations that you named: the healthcare provider organization that has Part 2 records, or the health plan that may obtain that, a vendor who may be facilitating the Part 2 records, or an HIE that's facilitating that exchange of Part 2 records. So the health plan that's paying for the claims. So each of these may be faced with the Part 2 challenges, but they're really focused on how it affects their immediate implementation. And so their perspectives are different. And having had to advise each of these, the focus definitely is different. And so you can't always translate what you're telling, for example, a healthcare system, and have that apply to a health plan, because the impact and the implications, and quite frankly, how those standards and the consent applies to that particular organization, the nuances are a little different. So everybody has to do their internal due diligence and understand, okay, am I a lawful holder? Am I getting this? Or am I directly a Part 2 provider or program? Or am I holding myself out as one? Or am I a qualified service organization, which is a type of organization under Part 2 that's sort of like a business associate that's holding the information on behalf of? And am I downstream or subcontracting this to any third party? And does that third party do AI? And how does that impact all of this? It goes on and on. And so the disconnect is they have different perspectives. And like that example I just gave you, the business associates that's subcontracting down the line, they have very specific, I don't want to say problematic, because that's, negative. And we haven't figured this all out. We're waiting for SAMHSA. SAMHSA's been giving some guidance, and some things remain unclear, which is not always great, but that's how regulatory work goes. You're not always 100% from the black and white of the word in the preamble of exactly how to do things once you get into the real world. So there's challenges. You have QSO vendors who are either EMR or AI or technology, which is many of your audience. And all of a sudden, they're getting Part 2 information. They're being asked to sign a Part 2 addendum to comply with Part 2. Well, what does that mean for you? What exactly do you need to do? You're telling them that you're complying with Part 2, but do you understand as a vendor, an IT technology vendor, what that means to be compliant with Part 2 as a lawful holder or as a qualified service organization? So the disconnect is that each one has really its own unique kind of thing, circumstances, and you really need to do an internal analysis based on what you do, how you get that information, and how you may be potentially disclosing it to third parties to see where you sit on that continuum. Like, I've been working with a number of vendors who I've been advising to tag Part 2 information that's coming in as it's getting ingested. And if it's getting commingled with other clinical data coming from their sources, it presents problems with compliance down the line. Because, for example, if it needs to get pulled or the information needs to get pulled or it needs to be shut down or it needs to be treated differently when you get a subpoena for enforcement, which is one of the Part 2 standards, how do you know which of the part, if it's all commingled, what do you know is subject to Part 2 when it's not? So you have two choices: either treat everything as Part 2, which is overkill potentially, or you have a way of tagging the data by its source. Well, this is coming from a Part 2 source, and I know that by this tag that I need to treat this different information differently, or I can somehow pull it, I can filter it, or either or keep it separate somehow, where if I need to aggregate it and commingle it, I do it in a shared drawer and then delete that, but keep the information, the originating information, separate. There's just so many operational questions and issues, again, depending on what shoes you're standing in. So that's sort of the disconnect. Like, each one has to process its own issues with compliance when we're talking about sharing that kind of sensitive data.
These are such great examples. Thank you so much, Helen. And I wish I could ask you 6 more hours, but, of course, if I could reserve one question for our final one here, I can't not talk about AI. So, of course, as healthcare moves more toward AI than we already have, big data, just multi-stakeholder data sharing, as you've mentioned, what principles should really guide innovation in behavioral health so that we don't sacrifice the trust that you talked about, autonomy, and ultimately patient choice in the process?
I think the theme is the same of everything we've been talking about is you either pay now or pay later. Is that the saying? I don't know. But the point is, like, it's best to invest the time upfront, understand the governance, understand what exactly is going on. How is your vendor vetting your vendors? Not all vendors are equal. Some vendors are coming from different industries that are not healthcare, and they're just not understanding the different nuances and quite frankly, the restrictions that healthcare, because they're used to dealing with a much more commercial space. So just understanding your vendor, understanding what you're intending to do with it. There's ways to do it. I'm not encouraging shying away at all. I'm just saying, again, the theme to do your due diligence, right? And that goes to governance. I think that's the theme, right? Governance, making sure you have a group, the right group around the table that's creating the plan. Okay, we're going to adopt AI. What are the issues? Who do we need around the table? What do we need to look at? There's operational issues, there's technology issues, and down the line, there's the legal risk and compliance issues. So not forgetting, that legal risk and compliance issues, because there's a lot of tentacles that go off that last one, right? Just giving an example, right? If the AI tool is taking notes or it's recording people, are you in a state that requires 2-party consent or 1-party consent to recording? Are you implicating or triggering any wiretapping? Are you getting the consent that's required? That could be different for every state. The privacy laws, is that AI vendor intending to reuse that information? Are they processing that information? Are they sharing it with third parties? It's de-identified. Well, it doesn't really matter if it's de-identified, because if you're using and processing the originating data in a certain way, then there's implications of that. You could be talking about intellectual property. You could be talking about other sorts of impacts of using someone's data in that way. Even the compliance bucket, like I said, operational, technology, all those. And when you get into the legal compliance bucket, just making sure you spend enough time there, understanding all the legal issues, and definitely just taking those one at a time and making sure you're hitting all those things before you're just going full force and in deploying things. And I find organizations are doing that. At least my experience has been. I think that they've been properly cautious, if you will, and just doing I've seen a lot of organizations put effort into doing those steps. So that's, promising.
You are such a wealth of knowledge, Helen. I thank you enough for taking the time to share your expertise with us. Where can folks learn more about you and your practice?
Oh, so yeah, there's a couple of places. I'm very active on LinkedIn. So if anybody wants to check out, I frequently post things there. We do have a blog that I encourage readers to go to. It's www.legalhie. HIE stands for Health Information Exchange, but it's just the acronym. So legalhie.com. It's a blog where we post our insights. There's a number of resources on there. There's both the free-facing, public-facing resource and article that you can subscribe and just get those. We don't publish too often, so you won't get inundated. And of course, there's a back-end resource that is for paid membership and paid subscribers as well. So I would encourage people to check that out. I also just want to give one more plug to Sequoia Project, we just released the operational consent for 42 CFR Part 2. So if your listeners can go check that out. We're looking for public comment on that. I worked on the work group that put that together. Again, the point here is we're looking at possible computable consent for Part 2. What do we do to begin to operationalize that? So I hope it's a really great resource for the public out there, and would encourage your listeners to go check it out and even submit comments if they have the time to do so.
For my audience, I really encourage folks to go rewind, jot down all of those resources, the website links. I can't emphasize enough. Thank you for developing these resources, Helen, and appreciate your time for sharing with us today.
It's my pleasure.
Thanks for tuning in to Expanding Access. We hope you're feeling inspired by today's discussion. If you've enjoyed the episode, subscribe and share it with your network. For more content and opportunities to get involved in transforming care, visit behavioralhealthtech.com. Until next time, let's keep pushing boundaries and expanding access together.